Good afternoon, everyone. Welcome to the third and last session of our Women's Health in Focus webinar series, hosted by the Office of Lifelong Learning and the Physician Learning Program here at the University of Alberta. My name is Denise Campbell-Scher. I'm the Associate Dean of the Office of Lifelong Learning and Physician Learning Program. Our office is committed to providing reliable updates and resources for clinicians, healthcare professionals, and everyone committed to providing the best clinical care for patients. The University of Alberta, its buildings, labs, and research stations are primarily located on the territory of the Niihau, Niitsitapi, Métis, Nakota, Dene, Haudenosaunee, and Anishinaabe lands that are now known as parts of Treaties 6, 7, and 8 and the homeland of the Métis. The University of Alberta respects the sovereignty, lands, histories, languages, knowledge systems, and cultures of all First Nations, Métis, and Inuit nations. So I'd like to start with a little bit of housekeeping information. If you have any questions about L3 program services or technical difficulties, please use the chat button on the bottom of your screen. If you have questions for our speaker, please use the Q&A feature of the webinar. Please review what's been asked and upvote those questions you'd really like to have answered. We can't guarantee that our panelists will be able to respond to all of your questions. A recording of the webinar and a Pearls for Practice will be sent via email to all of those that registered. Participants can claim CME credits and complete a personal development activity using the My Lifelong Learning Plan tool. And for more information, please visit the QR code to access this free resource. This activity has not been formally reviewed by the CFPC or Royal College. However, it is eligible for non-certified credit. Additionally, Main Pro Plus participants may earn additional certified credits by completing a linking learning exercise. So today, we're very pleased to welcome back Dr. Annick Poirier, the physician lead for the Women's Health in Focus webinar series, and our speaker, Dr. Lucas Vasas, who will be sharing with us some of the common signs and symptoms of genitourinary symptoms of menopause. And he's going to provide some information on how to counsel patients and review both non-hormonal and hormonal treatment options. Dr. Vasas is currently completing his fellowship in urogynecology here at the University of Alberta. He completed his residency in obstetrics and gynecology here as well. And he's passionate about medical education and has been heavily involved in teaching and mentoring roles throughout his residency and fellowship. And we're super grateful to him for making time to contribute to all of our learning today. And thanks to all of you for your time, and welcome everyone to the webinar. So Lucas, over to you.
Excellent. Thank you very much for that kind introduction. I'm back and forth between the OR, so that's why I'm in my scrubs. But today we'll be talking about genitourinary syndrome of menopause. And so I have a slide to cover hopefully all the questions that you might have in my slide deck, but I will try to get through all of my slides. I don't have any disclosures to make. And I did want to start with a little poll just to kind of see where everyone's at. So maybe I'll swap, if you have the chance to use this QR code to join the pre-presentation poll, but I will stop sharing and switch over to this one. So firstly, I just wanted to kind of poll what are signs and symptoms associated with genitourinary syndrome of menopause and get a sense from the audience. Okay, so we have a few things popping up. Dryness, itching, urgency, dyspareunia. Absolutely, all of these can be related. Incontinence, yeah. And this presentation will kind of go over all of this, but you've got some key ones listed here, absolutely. And dryness is definitely a big one. In terms of this history, a 70-year-old patient with symptoms of vaginal dryness and previous history of breast cancer, which of the following would be options for treatment? Okay. And then just to make sure we can get through all the slides, I'll go to the next poll. Which of the following hormonal treatment options have you prescribed for patients within the past year for genitourinary syndrome of menopause? Okay, so I see lots of options for the vaginal estrogen options. Okay, great. So I'm going to go back to my presentation here. Okay, so it's good to kind of get a sense of the lay of the land first, but in terms of this presentation, I'm hoping that by the end, you'll be able to identify the most common signs and symptoms of genitourinary syndrome of menopause, be able to counsel patients and review both non-hormonal and hormonal treatment options, and to discuss the safety profile of hormonal treatment options. And so my plan is to kind of go through these in this order to talk about of an introduction about GUSM, to go over patient assessment, the treatment options, and then safety. And there'll be some time for questions at the end. Most of the information that I have in my slides is from the Society of Obstetricians and Gynecologists of Canada guideline on menopause and genitourinary health. But there is a more recent guideline from the American Urological Association and the Society of Urodynamics, Female Pelvic Medicine, and Urogenital Reconstruction, and American Urogynecologic Society. And it's been endorsed by the International Society for the Study of Women's Sexual Health, Sexual Medicine Society of North America, and the Menopause Society. So most of my details are actually from this newer 2025 guideline. And it has a lot of, it's available readily online, and it has a really good breakdown of some of the evidence that they used to guide their recommendations. And it's very similar to the SOGC guideline in a lot of ways, but we'll talk briefly about kind of where there may be some key differences. So firstly, we'll start off with what is genitourinary syndrome of menopause. So this was formerly known as vulvovaginal atrophy, but the change in name recognizes that urinary symptoms are a component, whereas vulvovaginal atrophy kind of excludes the urinary tract. There's a spectrum of changes that are associated with decline in sex hormones. And although this is most commonly seen in menopause, you can have similar symptoms in anyone in a hypoestrogenic state. So, for example, postpartum with premature ovarian insufficiency or iatrogenic causes, like if they've had surgical menopause, for example. There's no consensus on diagnostic criteria for genitourinary syndrome of menopause. And it's important to note that symptoms can precede any physical signs of atrophy, but vice versa. So some patients may have signs that you can see on a physical exam, but not have any symptoms. The prevalence is difficult to estimate, but it's been reportedly as high as 50%. Some studies show that 90% of postmenopausal women had at least one symptom of genitourinary syndrome of menopause, but sometimes patients don't always connect their symptoms with the idea of menopause or with genitourinary syndrome of menopause. And it does have a huge impact on quality of life for patients. 55% of women with GUSM reported avoiding intimacy with partners, and other impacts, including sleep disturbance, social isolation, or self-esteem impacts, and increased healthcare utilization and UTIs. And so it all comes back to embryology. So when we look at the embryology of the urogenital tract, the urogenital sinus forms the vulva, vagina, urethra, and bladder trigone. And the pelvic floor musculature as well carries androgen and estrogen receptors. And so that's why the lack of hormones can impact all of these different areas. And estrogen has a lot of roles in terms of providing health for these tissues. So for the first, it supports normal epithelium and collagen content. It increases the production of acid mucopolysaccharides and hyaluronic acid, and it helps to maintain a normal microbiome. So the vagina normally has a non-keratinized stratified squamous epithelium, and there's usually thick root-gated vaginal tissue. The hyaluronic acid helps to maintain moisture and provide epithelial barrier function, while the exfoliation of these squamous cells and their breakdown releases glycogen, which is a substrate for lactobacilli, which is part of the normal vaginal microbiome. And lactobacilli acidify the vagina, which protect it from other pathogens. And so when we look under the microscope, we can see that on the left, there's a normal vagina with a thick stratified squamous layer. But on the right, in the atrophic vagina, we have a loss of those squamous cells and an increase in basal cells. So that protection from these epithelium is weakened. There's a number of atrophic changes that could be seen on exam. So I have a list of them here. There's things like vaginal thinning, hypopigmentation, that decrease in superficial cells and increase in parabasal cells, loss of rugae, loss of elasticity, increased friability, shortening and narrowing of the vagina. You can have labial and clitoral atrophy, as well as urethral prolapse, which we usually call a urethral caruncle, reduced secretions and dryness, altered microbiome, and an increased pH, so a less acidic vagina. Normally, the vagina should be roughly 3.8 to 4.5 on the pH scale. And in research, we often look at a vaginal maturation index, or VMI, and that's typically used in a lot of research studies looking at vaginal atrophy, where less than 5% superficial cells on this index represents atrophy. And on your physical exam, these are probably going to be the signs that you would be most likely to see and assess for in a physical examination. When we think about symptoms, we can think about symptoms for the genital tract. So dryness, burning, irritation would be the common ones that you would notice of the vulva and vagina. There can be sexual impacts, so lack of lubrication, discomfort or pain, dyspareunia, impaired function. And then in the urinary system, we also can see urgency, dysuria, and recurrent UTI as common issues. So next we'll move on to the patient assessment. And I think thinking about a differential diagnosis is really helpful in terms of your history taking and what to look for in physical exam to guide your assessment. So usually genitourinary syndrome of menopause is more like a diagnosis of exclusion, and we don't have strict diagnostic criteria for this condition, as I previously mentioned. So there's a number of other conditions that you should be assessing for and asking about or considering when someone tells you that they have symptoms of pain or itch or dryness, to make sure that we're not missing any other conditions that might be causing things. So things like vaginitis, and that can be whether there's STIs, so bacterial vaginosis or trichomonas, for example, or yeast infection, candidiasis. Assess for any exposures that could be causing vaginitis. So Desquamative inflammatory vaginitis, for example, can be idiopathic or secondary to exposures to certain medications such as biologics, or any alcohol in the vagina can be a factor for that as well. And then if patients are presenting with issues with like itching or irritation, especially lichen simplex chronicus, lichen sclerosis, or even lichen planus are diagnoses that come to mind. Other medications that could be contributing. So, for example, medications that could be leading to a low estrogen state. So, if someone is on anything like Lupron, for example, or if someone has other medications that could be leading to irritation. So, on that note, too, sometimes people who are diabetic might have more more frequent urination, or anyone who's on diuretic medications, and especially if they're incontinent, then that might be causing irritation to the vulva and vagina as well. When we think of chronic pelvic pain, we think of things like pain centralization or vulvodynia, myofascial pelvic pain, and those can all be correlated factors. Malignancies, so whether there's precancerous or cancerous changes of the vulva or vagina. Usually that would be related to HPV as well, but can be related to lichen sclerosis, UTI or recurrent UTI, overactive bladder, bladder pain syndrome, which is formerly known as interstitial cystitis, or other systemic diseases. So again, this kind of helps with thinking about how to go ahead with asking patients questions and what to look for on exam. So in terms of a history, it's important to consider a trauma-informed care approach, especially when it comes to a physical exam, and especially if patients are having issues with dyspareunia, chronic pelvic pain. That's certainly a factor that can be contributing, is a history of trauma. In terms of a history of presenting illness, it's important to be asking about vulvovaginal symptoms to determine what specifically that patient is experiencing. So are they having any itching, dryness, discharge, bleeding, pain, or burning? To assess for urologic symptoms, any urgency, dysuria, incontinence, voiding dysfunction, or urinary tract infection, the chronicity and severity of symptoms, any aggravating or alleviating factors, their vulvar skincare approach. So are they using soaps on the vulva or other irritating products? How are they drying the area? Are they using tight-fitting clothing? All of these can be factors that can impact symptoms. And then to do an assessment to see how this is actually impacting their quality of life, and what specific issues are bothering them the most, to be able to target those, and whether they've had any previous vulvovaginal diagnoses or previous treatments that they may have tried in the past. A gynae and obstetrics history is always important, asking about their menopause history, whether they've used systemic hormone therapy. It's important to note that patients who are using systemic hormone therapy for menopausal vasomotor symptoms of menopause may not actually get benefit from those hormones on the vagina. They may not. We find that often patients require both hormone replacement therapy and other treatments for the genitourinary syndrome menopause symptoms specifically. So that's really important to tease out. And it is safe to use treatments for hormone replacement therapy, like estrogen patch, for example, along with any other treatments in the vagina. And we'll talk a bit more about that later. Making sure the patient is up to date with their PAP if necessary, assessing for any pervaginal bleeding, especially postmenopausal bleeding, and an appropriate assessment for that. And often as a urogynecologist, especially, I'm thinking also about like prolapse, incontinence, and their past obstetrical history in relation to that as well. Past medical history and medications, especially any comorbidities that can cause or contribute to GUSM. So we talked briefly about that earlier, and their social history as well is important. So with all of this, thinking about their psychosocial and sexual function, making sure we ask about questions related to desire and arousal, any vaginal bleeding, whether it's related to intercourse or if they're having other signs of postmenopausal bleeding that needs to be investigated. Medications such as their like as mentioned before, any anti-androgen or anti hormonal medications. So spironolactone is another one to consider. Any oral contraceptive pill use, antihistamines, tamoxifen, all of those can contribute. And then assessing for their other comorbidities that could be impacting. So things like other vulvar conditions, which we've already briefly touched about, previous radiation, inflammatory bowel disease, other pelvic floor disorders, diabetes, sexual health, smoking, caffeine and fluid intake, and vulvar hygiene as well. All of those can be contributory. When we move on to a physical examination, it's important to offer a chaperone for patients, especially as part of a trauma-informed care approach. Make sure the patients have support, and it's also protective for you as the physician doing an exam. We first start off with an inspection of the area, and especially if someone has a history of pain, it's important to be able to discuss that you may not need to or may not get to doing a specular exam on that visit, especially if there's that history of trauma or pain where it might be too much for them on a first visit, especially if you don't have an established rapport with that patient or if it's a new referral, for example, or you just don't know the patient as well. So that's something to consider. But definitely an inspection to look at the outside would be a good place to start. And if the patient is able to go ahead with a speculum exam, that's helpful as well at this time. Most of what I've got for the physical exam here is just kind of thinking about genitourinary syndrome of menopause. But again, as a urogynecologist or gynecologist, I'm thinking also about doing an examination for prolapse and incontinence, which is why that's on here. And then a myofascial pelvic pain assessment. So that's kind of where some of my background contributes to this exam. But certainly looking at the external vulva genitalia, assessing if there's any skin changes, any discrete lesions or ulcers, whether there's been loss of architecture, so whether there is atrophy of the labia or clitoris, or whether there's any actual things that you can see like clitoral phimosis or adhesions of the clitoris or adhesions of the labia minora, for example, and that can be sometimes associated more likely with lichen sclerosis, but wouldn't necessarily be impossible with atrophy. But that would be something else to consider. A Q-tip test we often talk about. So using a Q-tip to assess for pain, so we can check for the nervous system functioning, make sure that there's normal sensation, normal reflexes, so anal wink and bulbar cavernosus reflexes, and then with a little bit of lubricant on the Q-tip, placing it on the vaginal vestibule to make sure that there's no pain associated with that, which would kind of be more like a chronic pain centralization situation as opposed to necessarily genitourinary syndrome of menopause. And then on a speculum examination, assessing for any introital stenosis, hypopigmentation, loss of rugae, dryness, whether there's any cervical stenosis or cervical ectropion, urethral caruncle, all of those factors that we talked a bit about in the last segment for the physical signs that can be associated with changes with lack of estrogen. So I have a few pictures here. So on the left here is a normal vagina. So you can see the rugae of the vagina, the nice pink coloration. It's a normal patency. Everything looks really healthy and moist. And then in the middle, we have some atrophic changes. So you can see that there is a bit of loss of adipose tissue, some smaller labia and reduced clitoral size. You don't really see the clitoris in the left-hand picture, but on the middle picture, it is a bit reduced in size. There's friable tissue, and then hypopigmentation and loss of the vaginal rugae. And then in the right-hand side, there's that example of a urethral caruncle. So that's essentially prolapse from usually from the posterior meatus of the urethra, and that's typically associated with lack of estrogen. And patients may be asymptomatic. If they are asymptomatic, they don't necessarily require treatment, and it doesn't necessarily require biopsy, but you should have a feel of the area, make sure that there's no firmness or nodularity or no associated discharge from the vagina when you palpate the area. Make sure that there's no other concerning features, no bleeding. And that would be part of an assessment for that. And then you can treat this with just vaginal estrogen, we'll talk a little bit about later, but providing estrogen to the tissue can correct that area. But definitely if the area is getting worse on follow-up, not better, or if the patient's having worsening symptoms, or if there's any firmness, anything that's odd about the exam, it's really firm and hard or tender, that wouldn't be typical, and consultations with urology would be appropriate for sure. In terms of investigations, it's worthwhile. Again, this depends a little bit on patient symptoms, but certainly if someone's having urinary symptoms, it's worthwhile completing a urinalysis and urine culture. You could do a vaginal swab for culture, assess for bacterial vaginosis, for example, or other conditions. If there's any abnormal lesions, it would be worth considering a vulvar biopsy of those lesions, as they could be the cause of the patient's symptoms and could represent precancerous cancerous changes. Or, for example, typically if there's conditions, this is a bit outside the scope of this talk, but if there's vulvar conditions like lichen sclerosis, often you can begin with management with corticosteroid cream therapy. And if there's no improvement on a subsequent follow-up, then consider biopsy at that time to confirm the right diagnosis. But if you're ever worried, it's definitely better to have a biopsy and confirm with pathology to make sure you're not missing anything. And then again, making sure their pap test is up to date. So in terms of treatment options, where to start? So this is where the SOGC guideline and the newer 2025 guideline from the AUA differ a little bit. So the SOGC guidelines suggest that non-hormonal options should be used as first line, whereas the newer guideline that's endorsed by the Menopause Society states that clinicians should offer low-dose vaginal estrogen as an option and use a shared decision-making approach, and that estrogen would be a reasonable first place to start. So again, there are a lot of different treatment options that we'll go through. These can be multimodal and used concomitantly. So you can use non-hormonal options along with hormonal options. So in reality, you don't necessarily have to have someone try a non-hormonal option first before trying vaginal estrogen. For example, you could even start them both at the same time. And that would be reasonable. And again, recommendations may depend on patient symptoms. So if patients primarily have symptoms with like dyspareunia or dryness related to intercourse, and it's only at the time of intercourse, then that may be a bit of a different conversation with that patient, especially depending on what their ideas about treatment would be compared to someone who's having irritation and dryness all the time, and maybe who's also having incontinence or urgency. There, again, we said there's non-hormonal, hormonal options we'll go through. And then systemic hormone therapy, like I said earlier, does not often completely treat GUSM symptoms. So it is safe to use low-dose vaginal estrogen along with systemic HRT for menopause. So in my practice and in our urogynecology clinic, we often recommend vaginal hormones as the first option or as part of a multimodal symptom management. And we'll go over some of the safety data and evidence for that later. There are a lot of different non-hormonal options. And again, this will just depend on your patient and what they are interested in trying, but there are a lot of different options that could be tried at the same time. So lifestyle and behavior modifications, for example. So when we think of changes here, we talk about vulvar hygiene, so avoiding any soaps, especially anything that's scented or irritating to the vulva, and then using a towel to pat dry or air dry, and avoiding use of a hair dryer. Some patients will report that they are using a hair dryer directly blowing onto the vulva to try and dry the area, and that is really irritating to the vulva. especially using loose fitting clothes or cotton underwear, and especially thinking about that at nighttime or considering not wearing underwear at night to help allow the area to breathe and to avoid tight fitting clothing in that area can be helpful. Bladder irritants. There's a lot of things that we know can contribute to urgency or even pain or discomfort in the bladder with bladder pain syndrome. So things like caffeine, alcohol, spicy foods, smoking, all can irritate the bladder. And so we talk about trying like an elimination diet. So patients try to remove one thing at a time, give it a few weeks, see if their symptoms get better. If not, they know they can kind of add that thing back in, and then remove something else. And that way you don't have to, because it's no fun to tell someone that they can't have any coffee, no like spicy food, like all these, like no acidic foods, all these things that people really typically like and enjoy. It's hard to tell patients to cut out everything that you enjoy out of your life. So that can be a tough sell sometimes, but for some people whose symptoms are really bothersome, that can make a big difference. And then sexual health and lubricants. So there's actually some evidence that regular intercourse and possibly masturbation as well can increase blood flow to the area, improve elasticity, and can reduce symptoms as well. On that same note, we'll talk a little bit more about pelvic floor physiotherapy on that note. Vaginal moisturizers can also be used daily, but the SGC guideline, I believe, does mention that when you apply the vaginal moisturizer, it should give 2 to 3 days of relief. And there's a few different options there in the guidelines. But anecdotally, a lot of patients say that the hyaluronic acid preparations have less irritation. So that would be Repagyne or Gynatrof. Some of the other options, like anecdotally, some patients have said that they feel worse itching afterwards. And that might just be because of what compounds are in some of those other treatment options. There's a lot out there. So usually the ones that are hyaluronic acid based are less irritating and more moisturizing. But you can also use things like water-based or silicone-based lubricants as well. And then pelvic floor physiotherapy, as I mentioned. So even if patients don't have symptoms of prolapse, pelvic floor physiotherapy can be really beneficial in terms of incontinence or avoiding dysfunction. In pelvic pain, especially if patients are having dyspareunia or tight or painful pelvic floor muscles on exam, then pelvic floor physiotherapy is really recommended actually on relaxation of those muscles to help relieve those symptoms. And there's actually some evidence that, again, using those muscles, working with a pelvic floor physiotherapist will improve blood flow to the area and improve atrophic symptoms without using any hormones as well. So that's another option. But sometimes, depending on coverage, may not be an easy option for some patients. And it does require a bit more work on a patient's part to complete those exercises. When we think about the hormonal options, low dose vaginal estrogen is like the first thing that typically comes to mind, but there are some other options out there now that we'll talk about. So the low dose vaginal estrogen is the most studied hormonal treatment option. Improvements have been shown in dryness, discomfort, and irritation, and dyspareunia. It may be as effective as anticholinergic medications in improving overactive bladder symptoms and significantly reduces the risk for recurrent urinary tract infections. So it is a great option for patients who are experiencing any of these kinds of concerns. And there's a lot of different formulations. So the nice thing is that patients can kind of pick and choose whatever sounds easiest for them. So there are estradiol inserts, and so there's two kind of main brands. There's Vagifem or Imvexi. Vagifem typically comes in just a 10 microgram tablet, I believe. The dosing for pretty much all of the estrogens is the same. We start with a loading dose daily for 14 days, and then reduce. Usually we say 2 times per week, but it is safe to increase to 3 times per week if needed, depending on patient symptoms. And then there's a few kind of key details on the side here for some of these options where, patients may choose one or the other based on some of these details. So with Vagifem, each insert comes on an applicator. So you get X number of applicators in a pack. So there's a lot of plastic waste. So sometimes people prefer avoiding that as an option because of all that plastic waste. But some people do like having the applicator. The one caveat, which I think I mentioned later in the talk, but it's always good to have it mentioned more than once, is that sometimes people try to push any of these products up as high in the vagina as possible. And when we think back to embryology, and I should have probably put a picture up, but the the abundance of estrogen receptors is in the lowest 1/3 of the vagina. So if patients are pushing their vagifem up all the way to the cervix, it's not sitting right where the estrogen receptors actually are, and they may not have as much benefit from the medication. So really, the applicator, and my blur is kind of impacting, but the applicator should just kind of be right at the opening to the vagina and then deployed so that the tablet is in that lower 1/3 near the opening. The estradiol inserts of Imvexi don't have an applicator and they're just inserted with a finger. So sometimes patients prefer that. But obviously, in an older population, patients with arthritis, that may be a bit more challenging. But that does come in 4 or 10 microgram options. So some people who are a bit nervous about using hormones are more willing to try a 4 microgram option because it sounds much smaller. But overall, when we think about all of these doses, the dose of like a 10 microgram estradiol insert is significantly lower than what's in an oral contraceptive pill with like an ethinyl estradiol, which is a much stronger estrogen. So overall, the dosing is significantly less. We'll talk a little bit more about that as well. The conjugated estrogen cream or Premarin, usually it's the cheaper option, is my understanding of the creams. The estragyne cream is a little bit more expensive, but the Premarin is rose scented, so sometimes that scent in there can be a bit irritating to the vagina, especially in that if patients come to you with a lot of atrophy, then sometimes applying any treatment is kind of really uncomfortable for the first like 1 to 2 months, and then as they use it and as the epithelial layer rebuilds and as the tissue becomes healthier, then they have less side effects and less issues. That's another important clinical pearl. There's also the option of the vaginal estradiol ring. So that is just replaced every 90 days. It releases about 7.5 micrograms of estradiol per day. It does not need to be removed during intercourse. If it does fall out, it can be washed and replaced in the vagina. But some patients do have trouble kind of removing or replacing it themselves and may need to have assistance with that. Otherwise, the only other point about the creams that I'll make maybe is that some patients find that they're a bit messy, but anecdotally, they may be better if patients have, say, like a urethral carbuncle. They can apply the treatment right to the urethral opening. So sometimes it can be a bit more helpful in that case rather than the tablets. But realistically, any of these options would be reasonable. In terms of other hormonal options, there is another product that's now in the market. So there is DHEA inserts. The generic name is Prasterone, or the brand name is Intrarosa. So this is a 6.5 milligram insert to the vagina daily. And this product utilizes endocrinology. So the DHEA is absorbed by the cells and then converted within the cells themselves directly to estrogen, testosterone. So they get both the estrogenic and androgenic benefits. And theoretically, there shouldn't be much systemic absorption to the bloodstream because there's no active product within the tablet itself. It's all converted within the cells. So some patients prefer this product for that reason as well, especially patients who are concerned about their risk for breast cancer, for example. But again, I'll talk a little bit more dedicated about breast cancer and that kind of a thing at the end. But this is a really good option for patients. But again, some patients have said that it's more expensive. I don't have any direct price quotes, but this is a little bit more expensive than the low-dose vaginal estrogen options. It's also, again, it's a bit newer, so it's not quite as well studied. So there have been studies that report improvements in dryness and dyspareunia, but it's not quite as well studied to discuss impacts on, for example, recurrent UTI or on urinary and overactive bladder symptoms, but theoretically it should be beneficial for those, but I just don't have the data to back that up at this point. These ovules also contain coconut oil, which can be quite moisturizing, which some patients really like, but it also can be a bit messy and there may be increased discharge. So often we recommend using it before bed so that patients don't have issues with like discharge or throughout the day. So again, this is that clinical protocol I was mentioning earlier. So reminding patients to insert to lower opening, near the opening, the lower 1/3 of the vagina, as opposed to as high in the vagina as possible. So again, if you're using any sort of applicator, just placing it at the opening. And then if you're using an applicator with cream to measure the dose, some patients may prefer to apply the cream to their, like measure out the dose of the cream with the applicator syringe, and then directly place it on their finger and apply it with their finger instead of trying to insert the syringe into the vagina. The other option that's a bit newer and available now as well is called ospemifene. It's a selective estrogen receptor modulator. The brand name is Osphena. It's a 60 milligram oral pill. It has improvements reported for dryness and dyspareunia. It selectively targets urogenital estrogen receptors without significant impact to the endometrium or breast tissue. So it may be a better option for patients with arthritis, for example, who may have difficulty inserting tablets or using a vaginal cream. But again, it is a bit more of an expensive option. And again, I don't really have good data to talk about recurrent UTI or OAB symptoms, but this is another option that is out there on the market. So if patients can afford it, and if patients are have difficulty with the other options vaginally and are okay with taking a pill daily, this could be a good option. So typically in terms of follow-up, symptom improvement should be expected within 1 to 2 months of treatment initiation. So if there's no improvements, then normally what we would do is plan to have a follow-up visit in the office with the patient, repeat a physical examination. Again, if there's any areas that look abnormal, or if there were certain spots that you figured would start to improve with treatment and they haven't improved, then considering a vulvar biopsy would be reasonable, just to make sure you have the right diagnosis, you're not missing anything else. Assess the patient's treatment compliance and proper use of the medications. And then you can consider alternative treatments or additions of other treatment options depending on persistent symptoms. So maybe adding in other non-hormonal treatment options to try to provide benefit. And then you can consider referral to other services for additional advice if patients really aren't showing any signs of improvement and you're not really sure what else to do. Always happy for provide extra help or advice over the phone, for example, with gynecology, or referral for vulvar dermatology if there's anything kind of unusual going on that you need some advice for. So now to talk about safety and evidence. There are a few non-evidence-based therapies that sometimes get mentioned or that patients will bring up to you. So there's insufficient safety and efficacy data to support the following treatments currently. So laser or radiofrequency devices, testosterone cream, and alternative supplements. So the laser or radiofrequency devices do get brought up in the SOGC and the AUA guidelines, and there's just not enough data to comment on whether they're safe to use and whether they're effective. I think some preliminary studies of the CO2 laser did show some benefit for GUSM specifically, but I've also heard, again, I don't know how regulated these treatments are. And so if patients are going and paying hundreds of dollars or more for these treatments and it's not standardized, there are patients who've also had complications such as burns or scarring in the vagina, which can make things worse. So again, at this point in time, not recommended based on the guideline, but there are ongoing studies and research into these as possible treatment options. Testosterone cream has often been used off-label for patients for libido, but does not seem to be effective alone in reducing GUSM symptoms based on the current studies. And then the issue with alternative supplements, they're not standardized. especially the herbal supplements, they can have unpredictable concentrations of active compounds, and current studies are limited or of poor quality with only short-term follow-up. So it's really difficult to provide recommendations on these for patients. And again, some of them may be systemic, so you may end up getting more estrogen or more uh, than you expect to the rest of the body, which could increase risks for patients. In terms of the safety profile for vaginal estrogen, there is no increased risk of stroke or venous thromboembolism. And in fact, in a secondary review of the Women's Health Initiative study, the risk of coronary artery disease and for all-cause mortality were lower in the local low-dose vaginal estrogen group. I don't have a good explanation for that because when we look at low-dose vaginal estrogen, there shouldn't be systemic absorption. When we've looked at studies at patients who are using low-dose vaginal estrogen, their estradiol levels in the blood are no different from another menopausal patient who is not using low-dose vaginal estrogen. So there's not any significant absorption typically. The only time where that may be different is just within the first 12 weeks of starting the medication. So patients who have really bad atrophy, that epithelial layer is really thin, then they may get more absorption because the blood vessels are closer and there's less that protective layer. So they may have a tiny bump in the serum estradiol, but it's not recommended to check that or follow up on that. And that as the tissue heals and improves, you should notice that that would be decreased. So in the studies at 12 weeks, their hormone levels are no different than another person in menopause. So thinking about that in breast cancer, again, as I said, treatment options have not been found to increase serum estradiol levels higher than the expected range for postmenopause. And in fact, the black box warning by the FDA has been removed for low-dose vaginal estrogen. And the AUA guideline from 2025 does say that it is safe to use low-dose vaginal estrogen, progesterone, or ospemifene in patients with a personal history of breast cancer. And evidence suggests that the low-dose vaginal estrogen is safe for patients with a history of BRCA mutations without increasing their risk of breast cancer. There may be some differences on some of the other medications. So, for example, ospemifene in Europe has no listed contraindications to use in patients with breast cancer. The FDA has warned against use in this context, but that is not on the packaging in Europe. And the AUA guideline does suggest that it is an option for patients with a breast cancer history. And then patients are often reluctant despite reassurance. And sometimes the oncology physicians aren't always on our side with this. So the issue with breast cancer patients is that they're often on tamoxifen. They are really like low estrogen states because of that. And they have really, really bad GUSM symptoms often. And a lot of the patients that I see, the vaginal moisturizers just aren't cutting it for them alone. But they've been told by their oncologist they can't ever be on low-dose vaginal estrogen, despite the safety data suggesting that there is zero increased risk with it. And the black box warning, again, like I said, has been removed. So some patients are more willing to accept the 4 microgram Imvexi as a lower dose, or the DHEA option. They may be more open to that, especially the DHEA where there's no actual hormone in the product itself. So some patients are find that more acceptable. With regards to endometrial cancer, there's also no significant increased risks of endometrial hyperplasia or endometrial cancer with the use of low-dose vaginal estrogen, progesterone, or ospemifene. Studies have noted minimal proliferation of the endometrium with ospemifene in particular, but no cases of precancer or cancer. Concurrent progesterone is not required for low-dose hormonal treatment options. So if you have a patient who has a uterus and they're only on low-dose vaginal estrogen, that's it. They do not need progesterone as well. If postmenopausal bleeding does develop, it should be investigated as per usual. But you do not need to perform endometrial surveillance with ultrasound or with biopsies just because someone is on low-dose vaginal estrogen. Only if they are having issues with postmenopausal bleeding. But otherwise, your thought is, oh, maybe I should do an ultrasound because this patient's on low-dose estrogen. not required. In our practice, usually, if someone does develop postmenopausal bleeding, we often do stop their vaginal estrogen during investigation. But the guideline doesn't talk specifically about that. So we typically do stop in those patients, but again, likely probably non-contributory based on the evidence. So I just wanted to go to a post-presentation poll. So give me 1 second just to set that up. And we'll go through that really quick. So you can use that code to join here. And then I will share my screen here. Okay, so this is the same question from pre-presentation. In a 7-year-old patient with symptoms of vaginal dryness and history of breast cancer, which of the following are evidence-based options for treatment? Okay, so this is pretty good. Like, everything was pretty good before the presentation as well. So everyone seems to be pretty in the know, which is great. But technically, based on the evidence and based on the guideline, both low-dose vaginal estrogen and vaginal moisturizers or lubricants would both be options. A 55-year-old patient initially presented with vaginal dryness for which you prescribed vaginal estrogen. She returns with worsening symptoms, especially vulvar itching. Examination reveals a raised, white-appearing vulvar lesion. What is your next step? There should only be 3 options. Sorry, there's this option 4. And that's great. I'm cheap, so I did not pay for slideshows, so I couldn't attach an image. But what this is supposed to be getting at is if there's like a raised white lesion, especially if it's like well demarcated, that would typically be associated with a precancerous or cancerous vulvar lesion, especially with pruritus. So I would recommend vulvar biopsy of the lesion as the first kind of next step in this case. You've already tried some treatments, haven't gotten better. There's an obvious vulvar lesion there. That's probably worth biopsying there. If it was more like widespread like whiteness in that figure-8 pattern, consistent more with lichen sclerosis, then I think starting with a topical corticosteroid would be reasonable, but you can always do a vulvar biopsy to confirm your diagnosis as well. A 60-year-old woman presents to your office for a routine pap test. You notice what appears to be a small, light pink mass protruding at the posterior urethral meatus. The area is soft and non-tender, and she is asymptomatic. What do you recommend for her? Okay, so I listed both of these as correct options. If they're truly asymptomatic, they have no issues, then no treatment really is required. But often we do recommend low-dose vaginal estrogen to help treat a urethral carbuncle. And that'd be a good first place to start. And then, like I said, if there's anything that is a concerning feature on exam, or if there's pain or tenderness, or if things are not improving, then you could consider referral. But these tend to bleed a lot, so I wouldn't recommend biopsy, definitely not in the office. I would just consider referral for this. Okay, great. So I think
Awesome, Lucas.
that's my presentation.
We got a bunch of questions. So, and we're 6 minutes to clinic. So We're
Oh,
gonna
okay,
we're
sorry.
gonna we're gonna drive through these. It's fantastic. I think you've covered a whole bunch of them. Um, Kenneth was just asking in terms of how to do biopsies on the vulva. So I think all of us would be very comfortable with skin biopsies, but I'm not sure that all of us would be comfortable with how to do a vulvar biopsy. So could you
Oh,
quickly
okay.
share with us how to do that?
Totally. So again, if that's not something that you do regularly perform, you're not comfortable, then certainly one of the good places that you can refer patients would be to colposcopy. So I think people often think about colposcopy for cervical pathology, but definitely if there's a concerning lesion or if you're want advice, colposcopy is a reasonable place for the vulva as well. But often you just use like the little like 4 millimeter punch biopsy or the keys biopsy. So little, the little round circular biopsy. You can use a little bit of local. I was taught to try to incorporate some of the tissue that's abnormal and then some of the tissue that's healthy within the same biopsy so that the pathologist can kind of compare. So usually you kind of do it along the border of the lesion. And then you can just usually throw like an absorbable suture, like a Vicryl, just usually a simple interrupted is good for that, like a 3-0. So it's usually pretty quick, a bit of local. It could be done in the office, but we do them a lot in the operating room if we're kind of concurrently doing another procedure. So definitely something to consider. But again, if you aren't comfortable doing that, then whether dermatology or gynecology or colposcopy would be reasonable things to consider as well, depending on what you're seeing. But yeah.
Okay. And Karine is asking whether there's any contraindications to vaginal estrogen if people have a history of confirmed endometriosis.
No, no. So again, the dose is really low. So again, we think of menopause and or endometriosis as hormone driven. So if someone's in menopause, the ovaries are not producing significant amounts of hormones anymore, then their endometriosis should improve. So the times where it may be more of a consideration is if someone is, for example, on Lupron therapy to quiet their endometriosis. You could still use low dose vaginal estrogen. Obviously, if patients do develop issues while they're on it, you can either stop or reduce the dose. So you could try like the 4 microgram Imvexy um, or just stop it and use alternative non-hormonal treatments. That would be all reasonable.
Okay. And then Genevieve is asking about whether or not you can use the Vagifem tab together with Permanent Cream if you're trying to get the external and the internal part. Is that
I I wouldn't use both because the issue is then you're getting double the dose.
okay?
So I would just use one or the other.
Okay. And Hai is asking whether Osphena and Imvexy can be combined to use alternatively, like every second month, for example, to minimize the risk of unknown long-term side effects.
Um, I I would typically try to stick to one of the hormonal options because that's what's been studied, and otherwise you risk increasing their exposure. We know that with the current doses, the hormone levels are within expected. So when you start to branch out to off-label things like that, in this case, you might have more increased estrogen exposure in the bloodstream. If you're thinking about alternating, um, like like on up to date, they talk about using like Imvexy or Vagifem, for example, cyclically, so using it daily for a few weeks and then giving a break period. But that's not typically what I would recommend or perform in my practice, so I can't really comment on that. And again, if you are prescribing Osphena, for example, that should be enough for all their symptoms. You shouldn't need to add Imvexy or something else on with it. So if you find that patient's symptoms aren't improving, you should assess what symptoms aren't improving and whether there's some other cause that you need to consider and just kind of do a reassessment of the patient.
And then Amanda's asking whether or not there's any preference in terms of choice for the low dose vaginal estrogen if in different scenarios, like for example, if someone used pessaries or
Hmm.
other things, is there a preferred?
Not necessarily. Again, it's whatever the patient's going to use. So if the patient is really, really opposed to using the cream and they hated if they tried it before, they hated it, and they're not going to use it, then there's no point in prescribing it. If a patient has a pessary, they should still be able to use the tablet option. They can use the cream option, either one. It's just based on patient preference. But they're all able to be used with a pessary, for example.
Okay, perfect. And Sheila and Temitopia are both asking about whether or not there's any age limitation in terms of how long you could continue vaginal estrogen for.
Nope. If patients are having symptoms and they're getting benefit, they can use it indefinitely. And for us in our practice, especially as urogynecologists performing prolapse surgeries, especially any surgery that we have that involves mesh, we tell patients that they're going to be on lifelong vaginal estrogen to protect against mesh erosion. So definitely safe to use indefinitely.
Awesome. Well, I'm mindful we're at time for clinic and for you to get back to the OR, Lucas.
Thank you very much.
So grateful to you for taking time and for putting this together. There are a couple questions in the chat. I think I feel like additional sessions coming on. There's PAP questions versus HPV screening questions, and there's more details about lichen sclerosis and other things. So I think this means we need to see you again. So, but thank you. Everyone's saying thank you, thank you, thank you. Yeah, it's just great. Really appreciate you taking time for this, Lucas.
Awesome. Thank you so much.